Well, welcome, everyone. I'm Jim Rathmel. I'm editor-in-chief for anesthesiology and anesthesiologist at what used to be called Brigham and Women's Hospital, is now Mass General Brigham Department of Anesthesiology, the merged department. You're going to hear from two of us from the institution. This is a journal-sponsored symposium, and the reason we put this together is because of the intense interest in this new and exploding group of medications and how we as anesthesiologists should think about responding to patients who come on these medications, to patients who we see in advance, who we want to know the best method for managing these medications, and the like. And you have three people who have become experts in very short order. They haven't been around long enough to become long-term experts. And they're going to share opinions. This is a rapidly evolving landscape. And there's no absolute right answer here. But there's a scientific way to think through this. And I think all three of the speakers today are going to talk through a little bit about how they think about this in various scenarios. So the first speaker is David Heppner. He's from Mass General Brigham. He is at Brigham and Women's Hospital. He is the medical director for the Perioperative testing center called the Weiner Center, after a major donor that put together a very, very nice physical plant for us that we've been in for years now. He's done many, many different roles in this space, and he'll share his expertise. So David, you're up. Thank you.
Thank you for being here. Thank you to the journal, to Jim, also Brian that sent that invitation. I think this is very pertinent. And I want to repeat what Jim said. There's a lot of opinion, but also science behind some of this opinion. So without further ado, I'll talk a little bit about the pharmacology and the implications for the perioperative period. If I could make it move, let me see. I'll just go like this. I do have some disclosures, but absolutely nothing to do with this topic, mainly anemia and up-to-date royalties. These are good medications. They improve glycemic control. That was the first approval. Obviously, we know people are using it to decrease weight, increase major adverse cardiac events. There was a recent publication from BJA. We're also working on that. Lower ischemic stroke risk and reduce decline in the GFR. There's a lot of use now for that and GFR. And because of that, those are the approved indications by the FDA. But people are concerned about the adverse GI effects, nausea, vomiting, delayed gastric emptying, and we'll discuss that. We'll talk about it. There is tachyphylaxis, no doubt about it, mediated by the vagal nerve activation. However, it does not go away, the effect on the residual gastric contents. I just read that from 2017 to 2021, it went up 40-fold, the use of these medications. And you could actually look at this graph when it was first identified in the early 1980s to approved in the early 2000s. The growth has been exponential. These are all of the medications. The only stuff that I want to point out is that other than the ones that have a very short half-life, like exenatide, which is about 2.5 hours, I thought you could put it on a depot and make it extended release. That's a daily dose, but everything else is weekly. And look at the half-lives. They're talking about 5 to 7 days. So if we want these medications to go away, you're talking about a month you need. It's not stopping 1 or 2 doses, as I'm going to show you from the pharmacology. Also, they do delay it, and that's the concern that I want to leave to you, the residual gastric contents. They work on the peripheral pathways. They delayed the antral contractions. Because of that, they slow the gastric emptying. And some of the agents, as I mentioned, there is tachyphylaxis, but the effect does not go away. This is a great work by Sen and colleagues from UT Houston. Basically, what they did is regular standard, they say, fasting guidelines, 8 hours, and they were looking at solids, thick liquids, or anything that was more than 1.5 ml per kilo. And by using gastric ultrasound, and that's an emerging modality, I'll touch briefly upon that, there's a 3-fold increase on the residual gastric contents with GLP-1s compared to patients not taking GLP-1 receptor agonists. They had a compliant diet, and gastric ultrasound was the key diagnostic tool. Then this is another study, like I'm talking a little bit about tachyphylaxis. Yes, it occurs early in treatment, but the risk diminishes over time. And what's important, this is from the FDA, as far as complications from the FDA adverse event reporting system. 50% had to do with these agents. So we really need to know the pharmacology, we need to know how they work, and we need to know how to make the perioperative management safer. So this is the crux of the problem. I think Ian Hobai is here from Mass General, the sister institution, also Mass General Brigham. And he basically said this is the higher incidence of residual gastric content in fasted patients regardless of symptoms. You do not need to have symptoms. Lack of symptoms does not equal normal gastric emptying. Yes, delayed gastric emptying, that's again the tachyphylaxis. And the symptoms may be more prevalent at higher doses, but they can present with any dose. And in this very nice written letter, Communication to Anesthesiology, they bring up the issue that fasting times is the single most important factor, and I hope to demonstrate that to you before my time is up. This is what we're worried about. I know Dr. Dixon is going to be talking, Anthony Dixon is going to talk about this, but all I wanted to bring up is this is the Swiss cheese of quality control. Whenever you get a complication, everything needs to align. But what I want to say is we need to recognize, because most cases of aspiration, it's because we do not recognize what are the risk factors, and we do not adjust the diet or the anesthetic technique. GLP-1s, they do enough sufficient gastric content, delayed gastric emptying time, the anesthetic impairs the function, and then there's so many factors that need to happen that Dr. Dixon is probably going to show you that the aspiration, at least in some of the databases, it's not showing that it's increased, and I'm not going to get into more details. That's your topic, but just to realize that the risk is there. And as we know, this is all a little bit of going to history land. This was the APSF, that they found some food particles when they were actually emptying the stomach contents, people taking GLP-1s, also getting about 200 or 300 cc's of fluid, of gastric fluid. And that brought up the first recommendation. I know Dr. Joshi was involved to hold it for 24 hours. I have to admit, I'm also involved with the ASA at the board level, and there was a lot of pressure from Mike Shampo, from basically telling the committee in practice parameters, as everyone knows, that committee takes about 2 years to go through a guideline. It takes 2 years, it needs to publish in Journal of Anesthesiology, it needs to be approved by the House of Delegates. They had a month to put something up, and they said, okay, maybe we should hold the medication 1 dose, but let's look at the data behind it. There's really limited evidence that holding works. The evidence is limited probably to case report, retrospective analysis, single-site prospective studies, and it does not guarantee safety. It's not patient-friendly. It worsens the glycemic control. Patients are going to have to restart maybe at lower doses, which they may not have, so there's also the socioeconomic impact and the increased side effects that the patients are going to have. This is something that I, with Daniel Prea, Bobby Jean Schweitzer, German peers, basically, if you hold, like let's say there's a 5-day delay in someone taking 1 milligram of semaglutide, does it go down? Yes, it probably goes from about 30 nanomoles per liter to about 20. Having said that, and the same happens if you miss 1 dose. Having said that, it goes from being on a 1 milligram dose to being on a 0.5 milligram dose. You still have a lot of medication on board. So holding 1 dose, not patient-friendly, doesn't do much, patients are going to have more side effects, it's going to be more expensive, and then there's the socioeconomic impact on the patients that may not be able to afford these medications. So now that we know, hopefully I have demonstrated that holding does not make a difference, and all of the major societies, and I'm going to show you, agree with that. What not everyone agrees or not everyone says the same is a diet, and I'll try to get now to the diet. So there's an increased aspiration risk despite fasting. Sen et al. Showed that to us. We believe many of us that at least Australia and SPACI, and also the VA just came with for the whole VA to do a 24-hour clear liquid diet. We'll go to that in a second. But we need to update the NPO guidance for the patients taking these medications, especially for the high-risk procedures and patients. This is data from two very, very large analyses. Patients having upper GI, demonstrating that they have increased gastric hypertension. They aborted the procedures because they saw food and they said, okay, we're not going to proceed with food there. Aspiration rates were the same. There's a more recent, just from July, another review article, an updated systematic review and meta-analysis demonstrating that if you do upper and lower, the residual gastric contents go down. So there's some data from 24-hour clear liquid diet from the GI literature. We worked very closely with Michael Camilleri. He's a GI doctor from Mayo Clinic. And there are two things I want to point here. One is there's no doubt that high fat, like if you look at the solid line, solid black is high fat, takes longer to empty than low fat, takes longer to empty to low-calorie liquid, takes longer to empty than water. So no doubt about it, liquids, solids, the fat content matters. The second point is gastroparesis. And you could argue that the GLP-1s, it's a risk factor for gastroparesis, or it acts as if you had gastroparesis. And then that's the difference between the solid line and the dotted line. So it takes longer if you have gastroparesis in someone with having a solid meal. So Dr. Perlas, actually, unfortunately, she couldn't be here, but that was the fourth topic. I'm no expert, but I have taken 2 courses, and I think all of us should know about it. If there are residents here at the ABA, that's part of the OSCE. So I think we should all be comfortable doing gastric ultrasounds. It enables real-time assessment. It's going to identify the residual gastric contents and guide the anesthetic. So this is just from, and let me see if I could do it. You could actually see right there, this is the liver, this is the stomach. That's probably what you see every time you put the ultrasound. This is, I'm pretty sure, what you see. But then this is a completely empty stomach. This is with a lot of liquids. They took probably like a lot of liquids that they took. This is immediately after eating. You cannot see anything. And this is, you could actually see food particles here about an hour to 2 hours after they ate. So I think we should be using more like that. And again, a group from Mayo, this was just published in Anesthesia Analgesia last week online. So they were still looking at what happens if we hold the medications and what happens. It was retrospective analysis, but they were looking at preoperative risk factors that affect the presence of the increased residual gastric content. If you hold the medication, you need to hold it for at least 8 days, which is 2 doses. And even then, when I showed you with the semaglutide, you still have medication on board. But what they found out is if you clear liquids diet for 21.3 hours or longer, then you really get rid of the residual gastric content. So that's a little bit of the data from the 24-hour clear liquid diet. I am going towards the end. Dr. Joshi, I'm not going to get into the Multidisciplinary Society, but what I wanted to point out, and also with the VA, which I just learned, the VA is probably the largest health system. The Multidisciplinary Society US, our colleagues in UK, SPACI, ANSA, VA, everyone is telling you, do not stop these medications. Do not stop them. What we do not all agree is on the diet. I think the Multi-Society says to only do it for the high risk. The UK actually tells you, don't do anything to the diet, just adjust anesthetic. SPACI and the Australians and the VA are telling you there's good data behind the 24-hour clear liquid diet, and hopefully I was able to show you some of that pharmacology. I'm a part of SPACI. I was one of the authors of this guideline. But I'm going to show you what I think it's valuable from that guideline and what may be complex and complicated. No doubt we should continue the medications. No doubt we should do the 24-hour clear liquid diet. Is there data that perhaps we should maybe let them have high caloric intake until 8 hours and let them have water until 4 hours? Yes, we're dealing with 2 letters to the editor that it's confusing to patients. it's not patient-friendly. So if you ask me, what I would really do is fasting for solids for 24 hours, NPO for 4 hours. I think it's much easier for patients to understand that, sort of tell them to go by the caloric content. And I'll address that. Dane and I and Bobby Jean will address that in the letter to the editor. Just wanted to bring up, so despite the recommendations, patients are going to show up either they ate the 8 hours before, and I think there's some data on holding it. So ideally, I think if they did a 24-hour fasting, they continue the medication, we should be doing the case. If the patients are symptomatic or not appropriately fasting, do the ultrasound. If it's empty, do the case. If it's full, I am not advocating for postponing cases. I think the vast majority of cases should proceed. If the patients are symptomatic, that's a different story, but adjust anesthetic. Do the gastric ultrasound. Don't do deep GA without a tube, or don't do it with an LMA. Adjust anesthetic also when you're doing the intubation. So in conclusion, I would say that the RGCs is the crux of the problem, and RGCs is the residual gastric contents. No doubt that they're increased in patients taking GLP-1 receptor agonists. There is absolutely zero data in holding the medication. Fasting times, there's not general agreement yet, but hopefully the data I demonstrated, and at least half of the societies, if not more, are recommending a 24-hour clear liquid diet for all patients on GLP-1 receptor agonists. And remember, people having colonoscopy do it, so I don't think it's onerous. And actually, I'll tell you what we have been doing at my institution and what we do at a lot of the institutions. If you let them have a light breakfast before 7:30, they're happy. I usually tell them, don't have a Big Mac, have some yogurt, whatever, so maybe some eggs, but sort of try to do it at low-fat content. There's emergent role of gastric ultrasound, as I have demonstrated, and failure to recognize as a risk factor for aspiration and adjust the diet and the anesthetic can potentially lead to catastrophic outcomes. Similar to Anjali, similar to Girish, there's a team of people that I could not do. Here you have Dane and Bobby Jean. We have Guillermo Pierres, he's an endocrinologist. Michael Camilleri, he's from Mayo. Yuna Choi, which unfortunately, she couldn't be here. I couldn't be on her session. She's an outstanding CA1 resident at the Brigham and Women's, helping us with database. Chelsea Messenger from the sister hospital, MGH epidemiology background, outstanding. And here, Ian Hobai, we're working across the Mass General system, across Virginia, Emory, Mayo. So I think it's important to do multidisciplinary studies, work with people that are not anesthesiologists and they have expertise. I have learned tremendously from Dr. Pierres and Dr. Camilleri. Thank you very much. There are this is not it. If you're interested in the topic on GLP-1s, there's a lecture tomorrow, there's a lecture on Monday, so feel free to go to them, and I'll be here for the answers and question and answer. Thank you very much.
So I think what you can see is, as a journal editor, my head has been spinning for the past year. And part of that is because this has changed so quickly. And there's a lot of nuance here, and I hope after the 3 sessions you can take some questions and answers. Do you want to go next? Yeah. Okay, all right. I was jumping the gun there. No problem. Oh, so Dr. Joshi wants to go last so we can correct everybody. There you go. I just heard that. No right answers here. Okay. So next is Dr. Anjali Dixit, who is a pediatric anesthesiologist and instructor at Stanford, who has been deeply immersed in this as well. So I look forward to hearing your...
Okay. Can you hear me? Or is this too high? Okay. Is this better? Yeah? Okay. Hi, everyone. I'm Anjali Dixit. I'm an anesthesiologist at Stanford. Thank you so much for coming to this talk, and thanks to Anesthesiology for inviting me. So I'm going to be focusing this talk on a paper that I published with my co-authors who are listed here in JAMA in April 2024. after summarizing that paper, I'll also be situating its findings within the broader context of several papers that have come out subsequently. So sort of how I think all of these papers should inform how we think about the risks of these medications in the perioperative space. So before I get started, my disclosures are that I've received funding from the NIH and from the Foundation for Anesthesia Education and Research, but the topics of those grants are unrelated to what I'll talk about today. So I'll try not to repeat too much of what Dr. Hepner said, but as we all know, the use of these medications has increased dramatically over the past few years. They were actually approved in 2005, but starting 7 years ago, their use increased due to being redefined as a first-line therapy for diabetes, along with metformin. And then we've seen expanding indications for heart failure, CKD, obesity. We're seeing research that these might help with addiction, even Parkinson's disease. And along with that, these medications have become quite ubiquitous in the United States. So in 2024, 1 in 8 adults reported using one of these at some point. 1 in 4 of those, interestingly, reported not getting the medication from their own doctor or a specialist, but getting it from an online provider, a website, a medical spa, elsewhere like a compounding pharmacy or abroad. And along with the rise of the use of these medications starting in 2022, we started seeing multiple case reports of regurgitation and pulmonary aspiration in patients taking these medications, thought to be due to delayed gastric emptying. And then we also saw, as Dr. Hepner mentioned, reports of increased gastric volumes via POCUS in appropriately fasted patients using these medications, although it's not clear what the positive and negative predictive value of those gastric volumes is for clinically significant pulmonary aspiration. So given all of this, societies representing anesthesiologists in the US and internationally issued guidance recommending withholding these medications for various periods of time before surgery. And Dr. Joshi is going to be talking about that. At the time that the guidance was originally published, the evidence was pretty limited, and there were no large-scale studies evaluating the risk of actual clinical significant pulmonary aspiration and respiratory complications in patients taking these medications. So given all of that, my group was interested in finding an actual population-level risk estimate for clinically significant aspiration in patients using these medications, because this estimate can help inform a risk-benefit calculation of withholding the medication. Obviously, the upside of withholding it is the presumed lowering of the risk of aspiration, which, as we know, can lead to significant morbidity and mortality. But there are also, there are also a lot of important downsides. So multiple studies have shown benefits to peri-procedural use of these medications, including improving perioperative glycemic control, which is independently associated with mortality, and lowering rates of readmissions for cardiac and non-cardiac surgery. And then, as we all know, asking patients to withhold medications is logistically complicated, leads to day-of case cancellations, which then often result in delayed patient care or surgeries never being rescheduled, and in turn affects patient satisfaction, outcomes, leads to financial losses. So we thought it was really important to know what the actual absolute risk was of pulmonary aspiration. And therefore, we aimed to, in a surgical cohort, assess the risk of clinically significant postoperative respiratory complications in a large population of patients using GLP-1 receptor agonists. We didn't think that it was likely that this could be accomplished as a randomized trial, just given the ethical concerns with randomizing patients to withholding or not withholding the medications, and also given that the outcome is really rare, so it would require a very, very large study to detect any difference. And so therefore, we conducted a retrospective cohort study using the MarketScan commercial claims database, which is a really large database representing about 250 million privately insured patients in the United States. And from that, we identified about 24,000 surgical patients with type 2 diabetes who either used GLP-1 receptor agonists or didn't. The others used a different pharmacotherapy for diabetes. And most importantly, we focused on emergency surgeries because these lend themselves to a natural experiment in which we're assuming that people who show up for emergency surgery to the ED and then undergo surgery the very same day were unable to withhold their medications. And so then we assume that we're getting a risk estimate for people who never stopped taking these medications. And so I've listed here the surgeries that we focused on, but these are common emergency surgeries: lap-api, lap-chole, operative management of hip fracture, ovarian and testicular torsion, transurethral interventions for uro or nephrolithiasis. And our exposure was patients who had a GLP-1 medication prescription fill overlapping with days supply overlapping with date of surgery. That was about 3,500 patients. And then we had a little over 20,000 patients in the comparison group who had type 2 diabetes and were taking a different medication for management of diabetes. The outcome we looked at was a composite of aspiration pneumonitis, postoperative respiratory failure, or admission to the ICU in the 0 to 7 days post-op. We also tested a narrower definition and a sensitivity analysis where we excluded the ICU admission. So we only looked at aspiration pneumonitis or post-op respiratory failure. And then for our analysis, we estimated the association between using GLP-1 medications and outcomes, adjusting for demographic variables representing the severity of the patient's diabetes, as well as other comorbidities, and the year and the type of surgical procedure. And then we did several sensitivity analyses re-specifying our approaches. So I'm not going to go through all of the results, but I just wanted to highlight here the left column is those who are using GLP-1s, and the right column is those who weren't. So those who were using them were more likely to be male, use more anti-diabetic agents, so probably had more progressed diabetes, and have a diagnosis of obesity. And the most common surgeries in our cohort were lap-api, lap-chole, and transurethral interventions for stones. So our overall unadjusted incidence of respiratory complications was not different between the two groups, 3.5% in those who were using GLP-1s and 4% in those who weren't. And then when we adjusted for all those covariates, there was still no difference. It was 4% in those using GLP-1s and 3.9% in those not. And the adjusted odds ratio was basically 1. And these results were replicated in our sensitivity analyses. We concluded, therefore, that there was no difference in clinically significant postoperative respiratory complications in the two groups. And to our knowledge, this was the first large-scale study evaluating the absolute risk of clinically meaningful pulmonary aspiration in patients using these medications. I do want to go over some of our limitations and just talk about them. So the first is that we focused on emergency surgeries, and so our results might not apply to elective surgeries. But I would argue that emergency surgery is its own risk factor for aspiration. And so any risk we could have detected between the two groups would likely be lower in an appropriately fasted elective population. Really importantly, we weren't able to evaluate rapid sequence induction or other full stomach precautions in this group. I would assume, given the types of surgeries that we included and the fact that the patient was presenting to the ED and going to the OR pretty much immediately, that most anesthesiologists probably would have used full stomach precautions. And so to me, that implies that those precautions on their own are likely safe and effective, and that we may not need additional medication withholding times on top of that. I didn't examine GLP-1s prescribed for people without, for people without diabetes. So GLP-1s prescribed for other indications weren't included in this, but I think people with diabetes, especially those with diabetic gastroparesis, are probably the highest risk for this outcome. And then finally, we didn't look at the duration of GLP-1 therapy. So as Dr. Hepner mentioned, there's some evidence that patients have more GI symptoms and maybe a higher risk of aspiration in the first few weeks of using these medications, and that tapers off after time. And so it's that's an area for future research. So after our study came out, there have been several other studies that have corroborated these findings. I've listed them here, the first three. All are large retrospective studies that have looked at elective surgeries. So as opposed to the study that I presented, which looked at emergency, these looked at elective. I think one of the drawbacks of these is that they weren't able to see whether patients were told to withhold the medication ahead of time. But all of them have found that there's no difference in pulmonary aspiration or pulmonary complications afterwards. I do want to point out the line at the very bottom. There's evidence in the endoscopy literature, as Dr. Hepner also mentioned, that there's a higher risk of aspiration pneumonia. This paper found a higher risk in patients getting propofol-based sedation for endoscopy, but it was not clear to me what the airway management was for those patients, and I would worry that most of those patients were getting deep sedation with a natural airway. So I think overall, all of these findings imply that despite very concerning case reports, patients using GLP-1s generally have a low absolute risk of clinically significant pulmonary aspiration, likely not that much higher than baseline. General endotracheal anesthesia is potentially safer for these patients than using a natural airway. So thanks very much to the ASA and anesthesiology, and also to all my collaborators, Eric Sun, Brian Bateman, Mary Hahn, and Michelle Auden. My email address is up here if anyone wants to reach out, and I'll turn it over to Dr. Joshi now.
All right, last but not least is Dr. Joshi, who is a professor at UT Southwestern in Dallas and associate editor for ANA and Up to Date. Executive editor, section editor for ANA. And he's written extensively in this domain as well. And I hope you're going to bring a little bit of the controversy in and where it's still unclear exactly what we should do. And then there'll be questions at the end. Thanks.
Thank you, Jim. I want to thank Dr. Rathmel for inviting me. This is a great honor. And obviously, this is a topic really close to my heart. There are a lot of controversies. My hope really is to present to you a real clear take-home message from whatever we have currently. As was said before, the evidence is really shabby and really poor. And yes, there are millions of papers, but all of them have significant limitations. These are my conflicts of interest. I've received honoraria from these pharmaceutical companies, but they're not relevant for this topic. So we all know that there is no question that the GLP-1s are going to be increasingly used for multiple other reasons. Not just diabetes and obesity, addiction, liver diseases, Parkinson's. There's so many indications that are now being shown to be these drugs are beneficial. So we are going to see more and more of these patients. The problems, as has been said, that it's not just the patients who are prescribed the drugs. The patients who are taking these drugs from spas and many other places, and now this fashion of microdosing, which is being started, which is a whole different issue in itself. And the concern, obviously, is delayed gastric emptying, leading to all sorts of recommendations because we are so worried about pulmonary aspiration. The ASA guidance was one of the earlier ones. Around the same time, Sparky also came up with their guidance, which was very similar to ASA, but Sparky wants to keep quiet about that and not even mention about that they also had initially recommended to hold the drug for 1 week. Nevertheless, then there are many, I can go on. I mean, this is just a few of at least 30 international guidelines, okay? So there's so much going on. There are 4 areas of controversy in my mind, and that we need to really sort them out. First is to withhold or continue. Initially, majority of the recommendations were to withhold for a week. And it was more of a pragmatic approach because, there were concerns of aspiration. Maybe if you withhold the drug for a week, at least some amount of the drug effect will go down. In fact, the paper that was recently shown by Dr. Pai, Sholu Pai, which is just published in ANA. I handled that paper actually. And that paper did show that if you hold the drug for an average of 7.5 weeks, for days, that is 1 week, but Dr. Hepner doubled it and said, oh, you need 2 doses to be held. No, it's 1 dose to be held. And this is where we're having problems of our biases, where we come up with recommendations based on our biases. So nevertheless, I'll go through, should we withhold or continue? The other concern which is happening right now, which I don't know whether your GI guys are facing it, there's more and more data coming up in GI literatures showing that patients on GLP-1s don't have good prep, though they have actually done that 24-hour liquid diet, etc. And there are a lot of cancellations from our GI people. So they want to go back to the old ASA recommendation and say, no, we're going to hold it for 1 week, which is obviously highly controversial. So the first thing which I'm going to address is, should we withhold or continue? The other controversies are obviously about fasting for solids, but the question is, should we fast regular ASA recommendation, 6 to 8 hours for solids, or 24 hours for solids? So I'm going to address that. Then the other issues, obviously, ultrasound is a great tool for us if we are, we want to find out if the stomach is empty. But the question is, should all patients have gastric ultrasound prior to surgery if they are on GLPs, or should we individualize it? Obviously, it's just impossible to have all patients do it. So how do we go about deciding that? And finally, you already heard about aspiration. That paper which Dr. Dixit presented is excellent. Do a rapid sequence induction, and most likely it's going to be safe. And that's what I'm going to discuss. So let's move on and start one thing out of the way. Majority of the recommendations emphasize do not withhold the drug. It's now fairly universally accepted for multiple reasons, which are already discussed. But even the multidisciplinary or multi-society guidelines, which the ASA is part of, and I was part of that, also emphasize that at this stage in time, do not withhold the drug. And you heard about the 4 to 5 half-lives required, basically to completely eliminate the effects of the drug. But more importantly, there are studies that have shown that the patients who had, for whatever reasons, had not taken the regular dosing, had the blood pressure shoot up, they had all sorts of other issues, that will be hyperglycemia. So there's a general consensus that withholding the drug is not necessary, it's not appropriate. What about the fasting duration? The British associations, the British Association of Anesthesia, along with the Irish Association, the British Diabetic Association, etc., they all recommend standard fasting time. That is the ASA recommendation of 6 to 8 hours for solids. The multi-society recommendation is that 24-hour fasting is appropriate for high-risk patient population, and I'll discuss with you what high risk is. And then there are other societies that recommend 24-hour fasting for solids, and then there's a variation about fasting for clear liquids. The Australians say 4 hours, the Sparky people say 6 hours. Nobody really knows. I don't know where this data comes from. It is literally, when the guidelines are published because they want to separate themselves from other guidelines. That's my take on it. So this 24 hours fasting comes from 2 papers. Nevertheless, that's only what we have. One of the and both are retrospective, very small number of patients. One paper compared the gastric content in patients undergoing upper GI versus colonoscopy and found that the retained gastric content with colonoscopy was significantly less, unlike the upper GI, and the hypothesis was that's because they fast for 24 hours. The second paper is on bariatric surgical population. Again, they fast for 24 hours. So the suggestion is that, hey, let's have them fast for 24 hours. We don't know it's 24 hours or 48 hours, but that data you now know it comes from 2 studies. But it's an appropriate way it goes. sensible way to go for now. But the biggest problem is the composition of clear liquids during the fasting period. And the Sparky guidelines, which are just published, God knows where they came up with 10% of carbohydrate loading for a few hours and then less than 10%. There is no evidence for that, literally no evidence. And that is the problem. And the evidence comes from theoretical data, which you saw the graph there, that, if you take 5% glucose, maybe, there'll be less duration of retained gastric content. But the bigger problem, again, is if you have a patient with diabetes and you give them carbohydrate loading, their blood sugar will go up. And that we learned from our enhanced recovery protocols. I've been very involved with the enhanced recovery protocols. I've worked with Henry Kellett. He's the so-called father of enhanced recovery. And at that time, initially, there was recommendation that we should have carbohydrate loading for patients for enhanced recovery. Soon enough, we learned that if a patient with diabetes, we did that carbohydrate loading, their blood sugar would shoot up. And then there were delays and cancellations because they came in with their blood sugars of 350 and all. So the American Diabetic Association at that time came up with the editorial saying, don't give these patients carbohydrate loading. And that's what has been recommended. So I'm very surprised that this recommendation comes from nowhere. So let's look at the high-risk population, because that's what the multi-society guidelines are. It says, let's identify the patient. You heard throughout the theme is, if the biggest problem with aspiration is we do not identify the patients appropriately. So let's identify the patient at risk. That way, it will heighten our approach, and obviously we'll take more precautions in that patient population. You also heard about tachyphylaxis, which is a real thing. And so the dose escalation phase is the phase after which the tachyphylaxis occurs. So once the patient's on the maintenance dose, because there's tachyphylaxis, most likely the effect on the delayed gastric emptying is decreased. And there is some data for that. So the patients at high risk are those during the escalation phase. The other group of patients who are at high risk are obviously patients with significant GI symptoms. Though there is a good correlation between presence of GI symptoms and possible retention of gastric content, as you heard, the flip side is not true. Patient may have retained gastric content, but may not have any symptoms, so please keep that in mind. And what contributes to the delayed gastric emptying from GI are the delayed gastric emptying caused by comorbidities and the drugs. In our multidisciplinary, multi-society recommendation, patient dose, or GLP dose, and duration of the drug was included. But subsequently, papers have shown that these two are not really high-risk patient population, high dose or long-acting GLPs. So it has now been removed from the high-risk part of the decision-making. Ultrasound, just one slide, as I mentioned, there is no question that ultrasound will help us. But the problem is, in busy practices, keep in mind 70% of all surgical procedures are done on an outpatient basis in freestanding ASCs. They are very efficient. There's no time to do that. And not everybody is an expert. That not all patients are suitable for a good assessment. So also, we got to do the gastric ultrasound in select patient population. It's just not feasible. And this is only a diagnostic tool, which even ASRA, which had a very good recommendation recently published, recommended that it should be done in select patient population. And that was also a conditional recommendation, by the way, because there's no data for routine use of gastric ultrasound. So based on what I just mentioned, this is the take-home message, and this is partly from the multi-society recommendations, which is basically endorsed by the ASA, days before surgery. Identify the patients who are at high risk. Patients during the dose escalation phase, patients who have GI symptoms, patients with delayed gastric emptying from other causes. The best approach in my mind is what we are doing at our place at Parkland Hospital is not schedule an elective surgical procedure during the escalation phase or if the patient has GI symptoms. By doing so, you remove all the logistic aspects of basically trying to have this patient fast for 24 hours for solids. So nevertheless, if they are going to be scheduled, then the high-risk patient population should fast for 24 hours for solids. For liquids point of view, clear liquids go along with the ASA guidelines. Obviously, if they are not at high risk, then standard fasting. On the day of the procedure, if they followed the adequate fasting guidelines based on the risk factors or not, and they have no GI symptoms, proceed. If they have GI symptoms, perform gastric ultrasound, or they have not followed the guidelines appropriately for fasting. That way you have a very selective group of patients you're going to follow guidelines for, or ultrasound for. And then obviously, if it's not possible to do an ultrasound or if it's not conclusive, best approach is rapid sequence induction, if possible. However, that may not be possible in so-called Class B facilities, the GI facilities that do not have anesthesia machine. And that's the area which we really need to know how to follow that, and that may be the area where we need to do gastric ultrasound in most patients. But overall, it's shared decision-making between the proceduralist or surgeon, the patient, and us. I do want to emphasize again that we, at least what I see in my travels and at my place, we're so worried about aspiration that we forget the basic rule of doing the right thing for the patient. What I mean by that is that most common causes of aspiration are inadequate anesthesia when the patient bucks or coughs, and then that gastric content which is retained comes up. So you may have gastric content, but may not get regurgitated if everything is done right. And so people are worried about regurgitation and aspiration, that they don't give adequate sedation for the GI procedures if they were going to do that, or they're so worried that they do not give adequate relaxation or do not perform laryngoscopy at the appropriate time when the patients got adequately relaxed. So cannot emphasize enough. Follow our normal precautions for patients at high risk of regurgitation and aspiration. Placing NG tube prior to surgery or procedure is also not appropriate because it's solids we are worried about, and the patients don't like it. You're not going to be able to suck out the solids through that small NG tube. And finally, do not forget that regurgitation can happen at the time of emergence or extubation, and so we got to be, don't do deep extubation in this patient population. Thank you. To summarize, I just want to kind of repeat. I thought I was done. Concerns of aspiration obviously are real. Yes, the data, broad data does not show that, but that's because they follow appropriate rapid sequence. In my mind, these are all hospitalized patients, not the patients who are having GI procedures. And we got to be, taking precautions because there is a signal of risk. Evidence obviously suggests that there is no evidence. The quality is very low, though there are many papers. So the best approach, in my mind, is to identify the patient at high risk. That'll basically make you do the right thing for the patient. Avoid the procedure during the escalation phase. Clear liquids for 24 hours in the high-risk population. Do not withhold the drug. And then low threshold for gastric ultrasound when there is in doubt. And low threshold for rapid sequence induction. Discuss it with the patient and the surgeons. Thank you.
All right. Thank you all. We have time for a few questions. Please.
Great. Jerry Lerman from Buffalo, New York. Couple things. There's a dose escalation period, which I interpret as a period of chronic use of the drug. So there's evidence with liraglutide that delayed gastric emptying after 3 months may be returned to normal. And in fact, it's patient baseline. The question is there evidence for any of the other GLP-1 drugs having returned to normal gastric emptying after a period of steady state use?
It never returns to normal. But yeah, there's data, there's tachyphylaxis, but it never returns to normal.
Well,
Like it's,
So, in other words, you cannot expect that there'll be no retained gastric emptying in patients who are now on the maintenance phase of the dosing.
okay. So the second question is, we have to talk about sedation. You referred to GI cases, but let's propose another case. The case of cataract surgery where we knock the patient out, retinal surgery, where we knock the patient out for 5 or 10 minutes to put in a retrobulbar block. Not to be intubated, of course, and then return to a steady state sedated situation. Now, how would you approach that class of patients with the whole genre, GLP background?
We've looked into that. It's only in the U.S. where patients who now retrobulbar block for the, most cases, very few patients get that nowadays. Nevertheless, sedation is done mainly only in the U.S. If you look at Canadian data or Australian data, European data, patients don't get sedation for retrobulbar block. So it's not always necessary. But even if you are going to do it, in my mind, and we have done it, we regularly give remifentanil, very low dose, and we have published this 20 years ago when remifentanil was just being introduced. So you can use drugs such as remifentanil, very short acting. You don't have to completely knock out the patient. The aim is to make the patient comfortable, not unconscious, when the retrobulbar block is done.
Okay.
And,
I'll
offline,
discuss that with
share the
our retinal
papers.
surgeons and find how many of their patients will be happy about that.
It'll
again, be interesting.
You can do whatever. I'm just giving you the approach which we follow in our practice, that use remifentanil, and hopefully, the patients, you talk to them, explain about the concerns of regurgitation. Most patients are going to be okay.
Okay. And last thing.
No.
there are too many
ASA
people.
guidelines going to change?
So I just wanted, I wanted, because Tracy Wool was here. She's here no
down.
longer.
Or
What
come
I
up
wanted,
here afterwards.
the point I wanted to make, the ASA is not a guideline, it's a guidance.
guidance, yeah.
For the guideline, it has to go through a 2-year committee. It has to get published in the anesthesiology journal. So I wanted to correct that. This is a guidance because of all of the
That's-
emergence data.
So none of them are guidelines.
Right. They're all just guidance,
Guidelines
preliminary.
need proper evidence. These are all guidance, consensus statements, or whatever you want
We'll
to
let
call
Bobby
it. but
Jean
they're
go
not-
and then you, okay?
You said
Oh, I said guidelines.
Hi, Bobby Jean Schweitzer. With all disclosure, I was part of SPACI and part of the the writers for the BJA as well as the anesthesiology article on our guidance from SPACI. And with all due respect, Dr. Joshi, there were lots of data. And I would suggest perhaps you don't say you have no idea what the data is based on if you've actually read the paper, because the references are in there. And by the way, it's Dr. Oprea, O-P-R-E-A, if you're looking for it, not opera. But, I think that, the other thing is that we've published in both BJA and anesthesiology, two well-known peer-reviewed journals, not the surgery, obesity, or something where I still have trouble finding the multi-society guidance. But two things that really concern me. You said on your final slide with the kind of differentiation was that no symptoms go ahead. But you had said just previous to that the no symptoms weren't reassuring.
That's the before the surgery, day of surgery, and actually it's in SPACI also, it says that if the patients had GI symptoms, that may not be appropriate. The day of surgery, if the patient has no symptoms, obviously there's some benefit, but you do gastric ultrasound. I think maybe people.
I don't think you were recommending that gastric ultrasound
before-
for those who had no symptoms. But moving along, you had recommended, I think, changed your mind
This is
about
the
the 24-hour.
multi-society guidance, which was endorsed by the ASA, and what I'm presenting is the multi-society guidance.
So I think you recommended 24 hours for liquids, but then you never said,
Solids, 24 hours for solids.
well, meaning stopping solids before and just liquids during that time. So it's saying the same thing. But when did you want us to stop those liquids? I don't think
The
you,
ASA recommendation is 2 hours. and
just
that's
the 2 hours.
Yes.
Okay.
And
thank
that's
you.
what everybody recommends.
I would urge you all to read the actual articles in BJ and anesthesiology so you can see what the data was based on.
Rear microphone. You can see this is a very calm topic. Everybody agrees. I've not been in the crosswinds of this controversy at all myself.
Adam Collins, I'm in Portland, Oregon now. So I don't even know where to drill in, but I guess, how about with gastric ultrasound? One thing I didn't hear said was, where did the normals come from? If somebody has a normal gastric ultrasound, for clear liquids, it's 1.5 mLs per kilo. That's
Correct.
considered normal.
Correct.
That's only that doesn't have anything to do with being predisposed to regurgitation. It was defined as a 95% normal. So we're going to take people who have a positive gastric ultrasound, and I don't think we're going to do an RSI. I think we're going to cancel them. Wow, way too many times. I mean, I think that's how people are going to interpret this.
But you could modify the anesthetic.
What's that?
You could modify the anesthetic.
I think most people are risk averse, and I think they're responding mostly to the sense, the fear of litigation, the fear of if I have a complication, what are people going to say, and whether these things are guidelines or not, they're what everybody's following. And both of them, I'm going to say it, I think they're both ahead of the evidence. The holding the drugs for a week was based on pretty much nothing and doesn't even make sense. And then the idea that we should put them all on clears for 24 hours when there's greater and greater numbers coming out that show there's actually not a problem. Like if the data that Dr. Dixit showed had come out 2 years ago, that the patients have gastric contents and yet they're not aspirating, we'd start to question our prior assumptions. The way I grew up is like, if anybody has anything in their stomach, they're definitely going to aspirate. There's anything that's in the stomach is just dying to find its way into the lungs.
But let me give you a counter argument. Let's say we have the ASA guidelines talking about 8 hours. And the reason they do 8 hours is because if you eat, you have residual gastric contents. So then we're saying that we don't care if patients are on GLPs and they have residual gastric contents. So let's not do the ASA guidelines because all that happens is residual gastric contents. I could guarantee you could eat patients until 4 hours, and you could do a large study, and finding an instance of aspiration is very, very small. I'm talking more about.
That's
I'm
the point
talking
I'm
more about.
making, is that it was rare and it's still rare.
Correct.
And there's no difference between the two groups as the numbers get bigger and bigger. There's no difference.
But you do have the residual gastric contents, and that's what the normal ASA guidelines say 8 hours. That's the reason they do it, because you want to minimize the chance of residual gastric contents.
And normal people are still going to see it like 5% of the time.
Correct.
But
So
I don't
normal
know.
is abnormal.
I don't understand your point that people are just going to cancel the case. No.
People should not
That's what I see all the time.
No, that is not true. I mean,
It's sort of wishful. So you think what would you think would
they
happen?
would do rapid sequence induction.
That would be.
And in
fine.
doubt, do rapid sequence induction. That's
Yeah.
That would be fine. But all these things talk about delaying the case. They talk about postponement.
not,
All
not
these
in, I
guidelines
mean,
talk about
you saw
postponement.
all three of us are on the same page with that regard. That
Only if they have symptomatic patients. And satiety is not a symptom. That's a normal side effect of the medication. But I think we should move to a next question. Vivek.
Yeah.
Yeah, so just one more question because we've got to get on ready for the next session. But please come up and let's have some more conversation for the last phase.
Thank you. I'm a gastroenterologist and the chair of GI at the Mayo Clinic. So
I love that. So you work with Dr. Camilleri.
do,
Wonderful.
yeah. And,
Wonderful.
I wish our GI meetings are as passionate as your anesthesia meetings. I had a question about moderate sedation. 50% of all endoscopies, about 50 million endoscopies are performed outside a major hospital system with gastroenterologist and their nurse. There's an argument that I've heard that moderate sedation may be safer with respect to having sort of more aware airway reflexes, and perhaps the risk of aspiration is lower in that situation. I was curious about your opinions on that, if there's any truth, and what your perspectives are on moderate sedation with GLP-1s. And the second is, I've always sort of struggled with POCUS and its sort of sensitivity and specificity. And I must declare, I'm one of the founders of a small company that has a capsule that you swallow in real time. It tells you a video image of the stomach, which might be helpful, but curious about moderate.
So what I would say, and I'll take it. So unfortunately, most of the institutions, including ours, extrapolate. But if you ask me, like you're talking about the ASA going from minimal to moderate to deep to GA. Moderate sedation, it's done by nurses, should be very light anesthetic. You could argue that you could do it just with a regular NPO and having the do not holding the medication. Obviously not in symptoms, obviously not on patients escalating the doses, not in the highest risk patients. A lot of that's my thought based on the data, but a lot of the institutions just extrapolate and do it for all type. But I'm curious what they do at Stanford and at Southwestern.
I mean, again, moderate sedation is very questionable by definition. If we give propofol, as I was alluding to earlier on, people are so worried that they're not giving enough propofol, and then when the scope is put in, the patient coughs.
But Jirish, propofol should not be part of
No, but I'm just saying that the whole moderate sedation, when you start using, say, midazolam and fentanyl, is what.
Yeah, at least at our institution,
It's a problem. We don't know how the patients are going to react. So I just don't want to get into that definition of moderate sedation, because you assume that if you're aiming for moderate sedation, there's a high likelihood of deep sedation. We never know which patient is going to go into deep. So follow the precautions appropriately. For the GI facilities that I consult with and I talk to them, is obviously you got to take precautions when there is a problem. But don't schedule them during the escalation phase.
Oh, right,
Whatever
that's right,
little bit benefit you get, whatever tachyphylaxis, even if controversial, is still beneficial. And then don't hesitate to do the proper way of deep sedation. Once the probe's in, that's fine. Now, coming to colonoscopy, they're going to be fasting for 24 hours for solids anyway. So it's not a moot point. So that's why I think it's not a big deal. We just have to follow through. And my last bullet point was, every facility, every practice needs to develop their own approach. Because you know your patients, you know the group you're working with. Come up with your own. This is only a sketch or a starting point. Then change the starting point based on your approach.
Okay. So, and the point, and I think what you're doing, and that's more, I want to make it clear, Dr. Josh is a good friend. So this is playful argument. No, but what I was to say is, in the perfect scenario, if you have like the true minimal sedation, but what happens is a lot of the patients, like if you have an institution in which they limit to 1 of midazolam and 50 of fentanyl, but I know we do not allow propofol, definitely. Like when it's the nurses, I think they have a max of 2 of midazolam and 100.
Never give propofol.
Correct.
No,
And the moderate, and that's what he's asking. That's moderate
He's asking
sedation.
about nurse-administered sedation.
Oh, so that's midazolam and fentanyl, and I think it's very questionable. We don't know when the patient is going to go into deep sedation. Some patients, 1 milligram or 2 milligrams is nothing. Other patient, even 1 milligram, they're going to deep sedation. We don't know. And then you start combining fentanyl, and then the patient's moving a little bit. Oh, let's give a little bit more. And sometimes it comes to 10 milligrams of midazolam. So it's a very questionable approach.
On the other hand, they do a heck of a lot of it without us, President. And
Only with the GLP ones. Now, we are being very specific
Yep,
with
got it.
this patient population. I'm not talking about others.
And that's part of the reason most of the institutions like ours extrapolate from, and so we do the 24-hour.
Thank you all very much for your engagement. I want to make sure we get started next time. If you don't mind coming up and asking your
Come
questions
up.
straight on up, we'll get ready for the next panel.